Hello, my name is Élaina Gauthier-Mamaril, and I am a philosopher of disability and scholarly podcaster. And at the moment, I'm also a postdoctoral research associate at the University of Sheffield. There's a picture of me on the right side of your screen in a circle, and in the picture, I appear as a smiling, light skinned Filipinx woman with short, dark, curly hair, and I'm wearing a brown yoke patterned sweater with kind of Nordic elements in light pink. It's actually a pattern by a Canadian designer. And my presentation today is about long COVID Crip doulas counter archiving disability culture through podcasting. So, the outline for today, I will give you some background. It's necessary to define some terms and to give you like why I'm doing this. And hopefully, if you have questions more about the podcasting aspect, you will be able to reach me through the details I will leave at the end. So, I'll give you a bit of background and then the why. Why am I proposing podcasting as a counter archiving practice? Why is this relevant to disability? And why I think people in the health humanities and in and around biomedicine and biomedical sciences might want to learn about this. So, specifically, I advocate for the need for an account of disabled cultural knowledge. A lot of what I'm going to say is about maybe like transcending, thinking about amplifying the voices of individual disabled people and thinking about how can we recognize cultural practices and cultural knowledge in disabled communities. So then part 3 will be the what. So I will be defining the key terms of what is a crypt doula. I did not come up with a term, you will see, but I will tell you how I'm using it. And then counter archives. Again, a term I did not invent, but that I am claiming for this kind of project. And then number 4 is about the how. So podcasting as care, why I'm using the medium of podcasting and why I think it is generative and provocative to do so in the context of the health humanities. And in conclusion, I will wrap this all up by relating it to a term that has been going around in multiple disciplines, but especially in critical disability studies around disability as method. What does it mean to do something disably, if you will? So, the background. My PhD was on looking at Spinoza's relational metaphysics in tandem with analyzing the NHS and NICE guidelines in the UK about clinical shared decision making. So how to, enact the person-centered policies that the UK started doing about 30 years ago. And this is what doing that work, which was the intersection of philosophy, sociology of medicine, feminist theory, and looking and analyzing legal documents on healthcare policy. This showed me that the laws and policies about person centered care are written with a fantasy of a hyper rational patient in mind. And so, because I was looking at relational autonomy, I was faced with this idea that the system is built to only recognize legitimate knowledge and autonomy from individuals who are deemed to be hyper rational. And there's always the bias that the doctor is, of course, rational and the patient is, of course, irrational. And so already we're not starting from a level playing field. But regardless, like there is no such thing as a hyper rational agent in real life. And interacting with healthcare services is always vulnerable in some way or another. So, this idea that, okay, with all the goodwill in the world, these policies were meant for a creature that does not exist. And then also the realization, which seems very obvious, is that biomedicine follows a progress narrative. You identify the problem, you study it, you find a solution, you make things better. And I am not here to dismantle that, and I'm not here to say that doesn't have a place, but I do see a friction when you come to look at how disabled people or people who are chronically ill interact with medical services, when this kind of cure narrative or like linear progress is not something that is either achievable or desirable. And then we have like a cultural uh showdown, if you will. And as I was working in critical disability studies and being a part of disabled community myself, that showed me that disabled cultures have predicate knowledge in addition to factual and experiential knowledge. So what I mean by that is a lot of the times with person-centered care, there is a lot of value placed on, you know, the patient's individual knowledge, like based on their own experience. And that is absolutely true. However, I make the claim that disabled people, and more than that, disabled collectives and communities that share different knowledge, can have factual knowledge and sometimes factual biomedical knowledge. Disabled people will really research their own conditions and teach themselves a lot of the things that their doctors don't have the time to look into, but also predicate knowledge. And by that, I mean knowledge that you can extrapolate, like logically, based on the factual knowledge and your experiential knowledge. Disabled people and disabled cultures can create knowledge. All right. So this leads me to why I want to do this specifically. So, shared decision making and person centered care showed me that they're the limits of the medical model of disability. So, the medical model is what is used, obviously, in medicine and healthcare, but it also underpins, I would say, most, if not all, of our laws and policies, which positions disability as a deficit. So, disability is something that is defective, that is outside detrimentally outside of the norm, and that we need to compensate and we need to fix. Now, this is not a popular model amongst people who live with disability, who are disabled. And so, disabled people for a long time have been advocating for the social model that says that I am unable to do certain things because society erects barriers to allow me. So it's not my body mind that is defective. It is the fact that society is built for a typical, what is considered to be a typical body. And then it's like, too bad, so sad, you don't fit that. I I agree with the social model, but I expand on it by being part of a group of disabled people and theorists that look into Crip theory. So Crip is a reclamation of the slur cripple. So it's akin to like the reclamation of queer and queer theory. And thinking about, okay, yes, we are disabled by society, but this also means that we generate our own kind of knowledge. Like, because by virtue of existing in the world as disabled, I have to relate to not only practical things of life, but fundamental human things like, what is it to love? What is it to have desire? What is it to feel purpose? All of these things. And so I saw from my own experience and from my academic scholarship that the medical model of disability really was not understanding what disabled people were asking for and were needing. And this was made especially salient during the height of the COVID-19 pandemic, which is, as you all know, an ongoing pandemic right now. And long COVID was seen by disabled people as a mass disabling event. You had millions of people. I think there in 2023 there were 2.1 million adults in Canada that reported having long COVID. And so that's already 3 years ago. And it does not include children who will live possibly 40 to 60 years with chronic conditions related to long COVID. And so we're seeing this as a growing population of affected individuals in need of chronic care in a healthcare system that is not hand structured to handle chronic care. I studied mostly the history of health policy and health systems in the UK, but there are a lot of analogies with Canada where at some point there were political decisions made that the healthcare system is made to serve the independent sick, aka those who, have an ailment or an illness or an accident, and then we can fix them and they can go back to serving the state and being productive citizens. And people who are chronically ill, even if it's by result of social conditions like poor housing or economic unrest and all of these things, they are still not prioritized in the current system that we have. So now we're having these millions of people, some of them disabled for the first time, having to rethink their identities. And the healthcare system is not structured to take care of them. And then there's the fact that long haulers, which is a term that people with long COVID have given themselves, are organizing and engaging to varying degrees with the broader disability community. So, again, this is a population that consists of a lot of people who had never had to think about disability before. Although I do want to acknowledge that some long haulers contracted long COVID on top of other conditions. So, it's not like a stark black and white situation. But I do believe this reveals patterns that I want to study. So, Crip doulas. It's a term coined by Crip ancestor Stacey Park Milburn. And Crip doulas refers to disabled people who support and accompany others during the transition into disabled life. And this is documented, for example, in the case of HIV doulas, especially in the early 90s when there were no drugs that really worked to prevent HIV and AIDS. This idea of people who had seroconverted who would help someone who's newly seroconverted to navigate their life, which might mean like very practical things, like how to access food and housing and advocate for themselves in that way, but also how you renegotiate your whole identity and what it means to be human and to be alive now that your whole world has changed. And so I see long COVID doulas as people who either have the condition themselves helping other people with long COVID, or they may be differently disabled. And so like myself, like I have a different chronic illness, but like I have shared with long haulers some tips and tricks and things like that. So you can have that relationship even though you don't share the condition. And I'm concerned with the cultural knowledge and practices involved in Crip doula work. And the second term I want to define is counter archiving. So, disabled lives are most often recorded in medical and criminal files only. And this is a very narrow sampling that becomes the basis of all historical and structural study. So, because we have a narrow data set, we are kind of forced to perpetuate a vicious cycle of not seeing disabled people as whole human beings. And counter archiving is the decolonial practice of community based, active, and intentional archive formation. So, long COVID communities are not historical. They are here, they are now. But I argue that there are many examples of Crip doulaship practice that we should counter archive to conserve and develop cultural wealth. So, I really want to call on long haulers now to engage in this kind of genealogical historical practice and to try and understand their current efforts in a broader context. So now we turn to the how. So I specifically am talking about co-creative podcasting. So I'm not talking about just a host interviewing people who with long COVID and putting that on the air. This is a project that I hope will get funded, that I hope I will get to do, but I really want to have the time and space to look at how we can engage different communities, including disabled people and people with long COVID, on how to choose the design, the tone, the themes of a podcast and have more of a hand in the editing and the curating process, whilst recognizing the limitations of like time and energy that come with disability. So the point of co-creative podcasting for me is to engage disabled people as knowers. So to start from the point of view that people have experiential and factual knowledge and the capacity to produce predicate knowledge. So we use podcasting to counter archive using the intimacy of the audio medium. Many disabled people will consume a lot of podcasts because it is something that makes you feel connected and that you can do almost anywhere, including in the dark in your bed. And so there is this idea of like a voice beaming into your skull that creates a parasocial relationship that I think is interesting when we are talking about having disabled people enthusiastically consent to sharing their knowledge. And also, by enthusiastic consent, people react really well to me when I ask them, and they are very happy to have full attribution, which is not how traditional qualitative interviews work. Obviously, for lots of very valid reasons, we want to anonymize that data. And I'm not suggesting we replace that, but saying there is something to explore about the empowering aspect of podcasting where people are encouraged or allowed to state their full name and affiliation, for example. And I think that podcasting allows us to use storytelling to reach beyond the systemic use of the medical model of disability. So I nor any other individual can dismantle completely um, the medical model, and I don't think that's feasible or realistic in medicine. But I think storytelling is a powerful way to like reach people who maybe not have thought about these things before, maybe not have engaged meaningfully with disabled people in their lives, to understand what this experiential, factual, and predicate knowledge may be. And also, podcasting can be done remotely, asynchronously, and in multiple sessions. It can bend to Crip time. So when I do this project, I really intend to make the process as caring and careful as possible to make sure that I am really changing the method of how we're gathering this information, creating the podcast so that it is a positive as much as possible and generative space. I also believe that podcasting can lead to provocative challenges to the current way we do participatory research models. We love to say we want to co-produce, we want participatory research. Well, what does that really mean? And I think the framework of the podcast already, as I've mentioned, invites us to revisit dynamic consent procedures and our traditional ethics processes, and also IP ownership. Who owns the final product? Do people have the right to retrieve their voice after the podcast has been published? What do we do with that? You can experiment for a variety of audiences. What if I work with disabled people who say, I don't want to talk to medics at all, and I want to talk to like the people in my community that like don't understand and are ableist towards me, and I want to speak specifically to different demographics? Or what if I want to speak to the prime minister and this is like the audience that I want to have? So we can experiment with a variety of audiences that way. And then I see this, the work that I want to do, as performing disabled led and disability centered working, as I already mentioned, around like the time frames, the ways of working, really starting from the point of view of we have people who have something to say. How do we make that happen? Instead of saying, well, it's difficult or it's not usual or it's not possible. I think with the medium of podcasting, because we're not used to it so much as academics, we can afford to experiment in that way. So I propose podcasting as a method that can be used to explore disability as method. So, in conclusion, disability as method is a cross disciplinary term that has been in use since the 2010s. I interpret it as using the individual, collective, and cultural knowledge born of living as disabled to interrogate the way in which we seek to understand our world. I propose that in the face of disabled knowledges being excluded from the logics of biomedicine, there is a need for counter archiving disabled knowledges of care. I argue that podcasting is a generative medium to accomplish this because of its provocative possibilities. Thank you very much. I have been Élaina Gauthier-Mamaril. You can email me at e.gmamaril@gmail.com. The QR code will take you to my website where I also have a contact form. I am on LinkedIn and Blue Sky, and on the right-hand side, we have a square of 4 of some of the podcasts I've done. So my main one is Massively Disabled, a long COVID research podcast. And then the one that is wrapping up now, Cripping Research Culture. I've also done Women of Questionable Morals and Philosophy Casting Call. You can find all my podcasts wherever podcasts can be found on my website, elenagotimamaril.com. And I have a dedicated website at massivelydisabled.com. And the following will just be a selected bibliography. So please just pause the video if you would like to take details. Thank you.